recording. So let's get started with the cytology. So just as an introduction to cytology, I want to let you know that cytology is a big bunch of the exam. There is a lot of cytology questions. It's I think even percentage-wise, they've mentioned that it's a big percentage of the exam is cytology, because cytology don't only include GYN cytology, you have also non-GYN cytology, including thyroid, head and neck cytology, GI cytology, and fluid cytology like CSF cytology and this kind of stuff. So you get a lot of cytology questions, and it's even reflecting on the RISE exams. I think if you guys took the RISE, you'll see that even in the RISE exam, you get a lot of questions in cytology. So you need to develop the sense of how you can reach a diagnosis in cytology, or just hit the right choice. That's the main thing. Like, I want to hit the right choice from the differential diagnosis that I see in the choices that I have. Like, I see a list of choices, so I need to hit the correct one. Also, cytology always, or I would say more than 90%, the question is about a provisional diagnosis. Like, what's your diagnosis? That's based on my exam, at least. I saw that most of the questions they are asking, like, they're giving you a picture. Well, is this endocervical adenocarcinoma? Is this endocervical adenocarcinoma in situ? Are these normal endocervical glands? This kind of things. They won't like ask you in a theoretical information related to the diagnosis entity. Like, they won't tell you this condition is associated with, or this condition is, except in I would say 10% of the questions that they might ask about, let's say the HPV pathophysiology in cervical cancer. Well, you might have a question on this thing, but they don't get into what they need from you cytology-wise is to be able to hit the best diagnosis or the correct diagnosis from the choices provided. I want also to say that cytology is a branch which is basically dealing with screening mainly. Of course, you might end up like giving discrete diagnosis in a cytology report, like give a diagnosis that, well, there's no malignancy here. All what I see is benign cells, like, for example, benign bronchial epithelial cells. And sometimes you give also a discrete diagnosis of, oh, I'm sure this is malignant. Like, I see small cell carcinoma because I see the cells with nuclear molding and this kind of things, or these criteria of the small cell carcinoma. So you give discrete diagnosis sometimes, or a lot of times, but a lot of times as well, you are in the gray zone. Cytology is the science where you might end up normally in a gray zone. Like, well, I see atypical cells of undetermined significance. Well, I'm not sure whether these atypical cells are just reactive cells or they are like frank malignant cells. So, and this is a lot of the times. So cytology, that's why I'm telling you, cytology is the science of developing a sense based on the experience, based on how much or how many cases you screen and how many cases you get exposed to. So you start developing the sense of applying the criteria real quick and being able to reach the correct entity regarding the diagnosis, whether it's frank malignant, frank benign, or it's a gray zone in between. And that's actually the same thing in the exam. So the same thing in the exam, you want to be able to get exposed to a lot of pictures to the point that when you see a picture in your exam, your eye starts applying the criteria automatically, and you start, even if you are not 100% sure that, for example, this is malignant. Well, I'm 80–90% sure. You're 80–90% plus the experience that you have based on that you saw a lot of images, you will end up reaching the correct choice. That's what you need to survive in the board exam in cytology. And to be able to do this, you need to get exposed to a lot of images and a lot of pictures as much as you can. I would say a lot of images, a lot of pictures, not a lot of cases. Well, a lot of cases, getting exposed to a lot of cases is good if you're planning to practice cytology as a cytologist. And you need to learn how you can screen the slide and screen the pap smear and go from back to forth, from a vertical and then go down and then go vertical again, this kind of things. Well, this is not required in the exam. In the exam, you need pictures. Pictures, pictures, pictures. A lot of pictures. See as much pictures as possible. Like look at a lot of pictures of benign endocervical glands. Until you are able, like when you see an image, you just, when you see it first sight, when your eyes hit the image, you say, oh, this is benign endocervical cells. That's how you will survive cytology in the boards. And surviving cytology in the boards, tell you something, is a big plus, a big bonus, because you end up surviving a lot of questions. Okay, so how can we approach this? Here's the approach. So the approach that I took for myself in cytology, and cytology, honestly, was one of the branches that I was comfortable in the exam. I didn't suffer in cytology. I don't remember suffering in a cytology question. So here's what I did. These are Curt notes. We know about it, of course. This is the famous, my favorite, Curt notes. However, I believe that, well, Curt notes is good to lay down the basics. However, it's not good only to rely on the images, of course, in the Curt notes to reach to survive in the exam. No, you need more. I mean, you need more pictures, and that's the plan. That's my plan here. So my plan is we will go over the basics in Curt notes, and then we will end up getting some more images to get our eyes trained to develop the sense of hitting the correct diagnosis, okay? That's the plan, and that's how you need to approach cytology for your exam. And that's why listening even to cytology lectures doesn't hurt, or looking up in cytology presentations, as much cytology presentations as possible, because all of the cytologists usually do in their presentation is they put pictures and tell you the diagnosis, picture and the diagnosis, picture and the diagnosis. That's what they usually do in terms of at least laying down the basics. And that's what I need you to do as much as you can. So we'll go over the first note here is the cytology basics. In this note, he's trying to let you develop the sense of how a benign cell look like and how a malignant cell look like cytologically. Like he always say that benign cell look like a bird egg, like an egg of a bird. This like huge egg, they call it robin's egg. So it's a huge egg, which usually has some like granules in the eggshell. So that's the same thing when you look at the nucleus of a benign cell. It's smooth nuclear outline or rounded smooth nucleus. And you have an evenly distributed chromatin. The chromatin is dispersed all over the nucleus. And this is what's producing this dots or this like dots in the eggshell. So it's the same thing, that it's dispersed chromatin. And sometimes you might see a nucleolus, by the way. You might see a nucleolus. It doesn't matter. You might see a nucleolus. But that's how a benign epithelial cell will look like. It's a rounded nuclei with a smooth, evenly distributed chromatin like a robin egg. He always say one approach is just to divide the nucleus into 4 quarters and compare how the chromatin look like in each quarter. When you see, if you see that the chromatin in the 4 quarters nearly look the same, like it's the same density as if the chromatin is evenly distributed all over the nucleus, this means that you're dealing with a benign nucleus or a benign cell. But in case of malignant cell, the key is having an irregular nucleus. See the nucleus looks really irregular here. It doesn't take this smooth, rounded contour. He always have this metaphor of saying that it looks like a rock. A rock doesn't have an even shape or doesn't have a smooth outline. It have like huge difference in the shapes and how they look like. And this is how the malignant nucleus always look like. So it's an irregular nuclear contour. It has irregular contour, and the chromatin here is not evenly distributed. It's uneven distribution, or what we call hyperchromatic chromatin. Hyperchromatic chromatin means, see, there are a lot of clumping here of the chromatin here and there, making the chromatin don't look or does not look evenly distributed inside the nucleus. So nucleus is irregular with uneven chromatin. See here, when you divide the nucleus into 4 quarters and try to compare the chromatin in the different quarters, they will not look the same. There's lots and lots of variability. Okay. Also, another thing to look whether the cells are benign or malignant is not looking at only a single cell. This approach is when you look at a single cell and you want to see if this single cell is benign or malignant. Another thing also is to look at the neighbors, like look at the whole cells around, look at the neighboring cells. If you see that the cells looks relatively similar, so this means that this is a benign, this is the benign condition. There is no pathology here, there is no malignancy here. But if you see lots and lots of variation in the shape and sizes, like what we say pleomorphism, like here and here, these cells doesn't look alike. It's impossible. That's what we call pleomorphism, and this is when we call malignant, or when we suspect malignancy, like this. But in the benign, like this, the cells look nearly the same. One of the things also that you can apply for a benign diagnosis or a benign condition is that you see cells are forming clusters. And these clusters are actually organized. They have an organization which is relatively reflecting the normal histology of the organ that you're looking at. For example, what are these? Anybody can tell me what are these? Anybody can unmute and tell me what are these? These are benign.
Endocervical.
These are what?
Endocervical.
Nope.
Oh, that's not even a.
That's a ciliated epithelium, right?
Yeah.
This is ciliated epithelium. You see the cilia here, right? So when you see cilia, this is not endocervical. Endocervical, usually you see vacuoles in the cytoplasm at the apex. But here you see cilia. This could be like benign bronchial epithelium, for example. When you see these like tall columnar cells, see these tall columnar cells, and you have cilia on the apex, and the cells are making cluster, and the nuclei are nearly look the same. The cells look the same, and they are forming clusters of ciliated cells. That's what we call benign. And in this case, I would say benign bronchial epithelium. It might be tubal as well, because the tubal epithelium is also ciliated, but who knows? But this is likely to be a benign bronchial epithelium. Like this as well. See this cluster? This is what we call the honeycombing. The cells are forming a honeycomb. And the kind of cells that usually form these clusters of honeycombs, which look like the honeycomb of the bees, this is epithelium, usually epithelium. Any benign epithelial cluster usually form a honeycomb. Like we will apply this honeycomb as a metaphor in benign endometrium, benign like pancreatic epithelium, or benign, biliary epithelium. Any benign epithelium, they form clusters of well-differentiated cells which look really alike, rounded and look like each other, forming a cluster which looks like a honeycomb. Okay, so that's a kind also of benign epithelial cluster, organized cell clusters of polarized cells, and maybe forming a honeycomb or a picket fence. Picket fence means like the fence of the backyard, like this one, picket fence. That's a picket fence, like this ciliated epithelium that you see here in this picture. However, on the other side, the malignant cells, well, you might have malignant honeycomb. See, like this honeycomb. When this honeycomb turned malignant, it becomes like this, as you see. They call this drunken honeycomb. Drunken honeycomb. This means that it looks like a honeycomb, but it's like a distorted honeycomb architecture. What's distorting this architecture? The cells are becoming discohesive because they are becoming malignant, and they are losing their ability to respect the space of each other. So they are becoming discohesive, and they are even becoming pleomorphic. Some nuclei are getting really big, other nuclei are really small. So both of these factors are distorting the honeycomb architecture and becoming a drunken honeycomb. That's a malignant version of the honeycombing. Of course, the same thing here. You see large prominent nuclei, irregular nuclei, and still you see the clustering of the cells. But these are malignant clusters, unlike the other side, which are benign clusters. So see here, you see large, prominent, large nuclei with prominent nucleoli, like see this nucleolus, you might see this, the nucleolus, and there is another important feature for the nucleoli of the malignant cells is that they are macronucleoli. You need to remember this, macronucleoli, like a nucleolus which is big. It's as big as saying that you are having a nucleus inside the nucleus. This is what we call macronucleoli, because micronucleoli might be present in some reactive and benign conditions, just letting you know. Okay, this is what we call macronucleoli. Yeah, it's a size, it's nearly a size of a lymphocyte. Yeah, I agree. So prominent nucleoli, sometimes, not all the time, just make sure. Frequent mitosis, and sometimes you have these atypical mitosis figures or atypical mitotic figures. This is a sure sign of malignancy. You would never see this kind of atypical mitosis in a benign condition. Also, one of the key classic malignant patterns that you see in cytology is the nuclear molding. Of course, you see huge nuclei, you see huge nuclei. These nuclei are nearly occupying the whole cell. You don't have any cytoplasm, to the point that all what you see is just nuclei. These nuclei are tightly packed together, and they are molding inside each other. See? This nucleus is molded inside this nucleus. And this is what we mean by molding, nuclear molding. Nuclear molding is specifically a feature of what kind of cancer? What kind of cancer shows this nuclear molding? No, I'm saying
Small
cancer.
cell.
What? Small cell carcinoma, exactly. Small cell carcinoma. Anywhere you might get small cell carcinoma. Small cell carcinoma is widely spread. There's small cell carcinoma of the lung. There's small cell carcinoma of the prostate. There's small cell carcinoma of anywhere. So anywhere you get small cell carcinoma, you get the nuclear molding pattern, and you get the exact same pattern that you see right here. So you need to make your eyes used to this pattern to the point that when you see it, you say, ah, I will choose small cell carcinoma on whatever this biopsy is taken from, or whatever this needle aspirate is taken from. So that's what nuclear molding means. On the other hand, there's no nuclear molding in benign conditions. Cells might adhere to each other, but they are not molding together. And there is no nuclear molding at all. The nuclei are rounded, they look nearly alike. So no nuclear molding in benign conditions. Sometimes you see cannibalism. Well, it's not a common feature, but sometimes tumor cells eat each other. and you might end up seeing a multinucleated cell, like a cell inside a cell. This is what we call cannibalism. Tumor cells eating other tumor cells. Often you'll see that the cells are having high NC ratio, the cell which was eaten and the cell which ate the other cell. Both of them have like high NC ratio, such a huge nucleus. And it's usually happening in mucinous carcinomas, like this thing. This is mucinous carcinoma. And you see the mucin vacuoles here in the cytoplasm? You need to have this kind of eyes. The eyes which can like see these mucin vacuoles and say, oh, this means I'm dealing with some kind of mucinous carcinoma, adenocarcinoma, something of this kind, something of this flavor. So you often see high NC ratio here. On the other hand, on the other side, you might see phagocytosis also in benign cells, but it's usually macrophage phagocytosing other cells, like in this case. This is the nucleus of the macrophage, and it's phagocytosing other cells. And all the other cells which are phagocytosed by the macrophage, you'll see that the nucleus are very rounded, regular. There is no prominent nucleolus, no pleomorphism, often low NC ratio. Okay. You need to know that usually when you deal with a carcinoma, it's either an epithelial cell carcinoma, which is a carcinoma of the epithelial cell, or adenocarcinoma, which is carcinoma of the glands or malignant glands. In epithelial cell carcinoma, you usually have cohesive clusters. That's what I'm saying. There is still clustering, but the clustering is a cluster of malignant cells. So that's what we call drunken honeycomb. You still preserve your honeycomb architecture, but this honeycomb architecture is distorted by how pleomorphic the cells are and how the cells are getting relatively discohesive from each other, but they are still retaining their feature of being existing in clusters, like a carcinoma. So the cells are relatively large in size with abundant cytoplasm sometimes, but you have extreme nuclear pleomorphism and prominent macronucleoli. Like here, see this macronucleolus? See how big this nucleolus is? How big this one? Oh, yeah, okay. And the cells are the nucleus is very huge in size, as you see right here. And right there, see, there is significant nuclear pleomorphism. And you sometimes see the dirty background. What's a dirty background? Necrosis. Necrosis in the background. You feel like, look at this picture. You feel like this picture on low power, it looks so dirty. The background looks so dirty, but this is not a good picture, not a high quality image. But can anybody tell me what is this? Can anybody give a shot? What this could be? Like
Apoptotic cell?
it's carcinoma, but what kind of carcinoma do you suggest based on what you see? Well, somebody is saying, well, I see some mucin, possibly. I see some mucin, possibly. Well, possible. Yeah. You see like some kind of vacuoles here. Might be clear cells, right? It could be clear cells. So this could be clear cells, could be mucin, could be anything. And what about here? What do you see? What is this? No, I'm asking what is the one that I highlighted? What is this?
Pseudo-inclusion.
Yes, that's a pseudonuclear inclusion. Pseudonuclear inclusion is a feature of papillary thyroid carcinoma, or PTC, papillary thyroid carcinoma. On the other hand, this is epithelial, okay? This could be, by the way, it could be adrenal, it could be renal. It could be renal cell carcinoma, RCC, clear cell RCC. Who knows? And this is a kind of epithelial line. But see, on the other hand, this is how adenocarcinoma looks like. Adenocarcinoma, you might see intracytoplasmic lumen or intracytoplasmic mucin globule. Or you might see the cells forming these like pseudoacini, forming circles, forming like circles around each other and forming pseudoacini with some kind of amorphous secretion in the middle. That's what we say. When we see this, we definitely shoot for adenocarcinoma. So adenocarcinoma, they try to form some glands, they produce mucin. The cytoplasm often appear micro or macro vacuolated. Micro or macro vacuolated, fluffy, granular. See, like this cytoplasm. Can you see this cytoplasm? It looks like it has like small vacuoles. That's the delicate, fluffy to granular cytoplasm. And you see that the cell borders are not so prominent. Compare this to these cells. See, these cells, you can clearly identify each cell as a separate entity. And see here, here is one cell, here is another cell. So you still can clearly identify the cell borders. But here, you cannot. The cells is like relatively like as if they are mashed together. Sometimes you have signet ring cells, of course, like this one, with a single huge intracytoplasmic vacuole or intracytoplasmic globule. That's the signet ring cell. Or you might see that the mucin is polarized to one side in a columnar cell. On the other hand, squamous cell carcinoma, you must be able to identify the pattern of squamous cell carcinoma. The key thing that we shoot for in squamous cell carcinoma is what? Anybody remember the tadpole? You know, the tadpole. The tadpole means like you see a cell with a big, huge tail. That's the tadpole cell. When you see the tadpole cell of a cell or a cell which is elongated, sperm-like, they sometimes say this. Yeah, sometimes they say sperm-like cell. That's when you shoot for squamous cell carcinoma. But please don't rely only on tadpole, or don't rely only on seeing keratin in the cytoplasm. Like here, we see this pink or dark pink cytoplasm which has keratin. Well, that's squamous cell carcinoma, possibly keratinizing even. But you should not rely only on tadpole, on having tadpole cells and keratin in the cytoplasm. You should also look at the nuclei. You need also to see nuclear pleomorphism, like see the size of this nucleus, different from the size of this nucleus, different from the size of this nucleus. So when you see nuclear pleomorphism, sometimes dirty background necrosis, tadpole cells, keratin in the cytoplasm, that's SCC. What if I see tadpole cells and I see keratin in the cytoplasm, but the nuclei are fairly regular? The nuclei are very regular. The nuclei look very benignish or benign. What might be the diagnosis here? In a cervix, in a cervical cytology, for example, it's going to be parakeratosis. Could be like some kind of parakeratosis or squamous metaplasia. Might not be squamous cell carcinoma. So these are squamous cells, but they are not malignant. They are just like metaplastic squamous cells, or they are just parakeratotic squamous cells. You have parakeratosis. So squamous cell carcinoma, it produces keratin, which give a bright orangish or a bright pink cytoplasm. And sometimes you see the keratin pearls, and the cytoplasm appear dense with distinct cell borders. And you see, of course, the tadpole cells, as we mentioned before. Neuroendocrine features. You need to get your eyes trained on shooting for the neuroendocrine, the carcinoid tumor, and neuroendocrine tumor, neuroendocrine carcinoma, these kind of things. So what is the clear, or what is the key nuclear feature that when you see, you say that this is neuroendocrine tumor? Salt and pepper. And this is what he put right here in the notes. I love the way he presented, like this salt and pepper chromatin, which you see here in this nucleus, and this nucleus. I understand that it looks really tricky. Sometimes when you have dense chromatin, which condense in some areas of the nucleus, you might say, well, this is salt and pepper. Sometimes salt and pepper trick you for lymphoma. And sometimes this neuroendocrine tumor trick you with lymphoma because the cells are often discohesive, like lymphoma. And they have this kind of discohesive architecture with this kind of weird looking nucleus. So you might say, this could be lymphoma. I understand, but it's the matter of how many pictures you see. When you see more pictures, and based on the site from which the biopsy is taken, you usually end up reaching the correct diagnosis most of the time. Of course, you have immunos in place. Come on. I mean, in real life scenario, you will have a cell block and you will be able to do immunos. Synaptochromo will tell you what it is. But the thing is, I'm talking about the exam. In the exam, they sometimes don't give you any immunos, and they just rely on your eyes and your feeling. I feel like this is a neuroendocrine, it's not a lymphoma. And your feeling become more towards the correct side based on how many images you see. So salt and pepper chromatin appears so stippled, and you might have some kind of granular cytoplasm with secretory granules. These usually have this kind of chromogranin. See this lymphoma? Oh my goodness. See how this one looks really like this one? Not really, actually. If you apply the salt and pepper rule, you will see how this nuclear condensations in a salt and pepper pattern differ from the nucleus here. This nucleus also has some kind of condensation and condensed chromatin, but it doesn't look really like a salt and pepper. And this is based on how many images you see. If you give me a picture and you try to trick me out, I will tell you, well, most likely this is lymphoma. This one, no, this is most likely neuroendocrine tumor. And usually most of the time I will end up being correct. But in real life, I told you, you have immunos. You don't have to bother about it. So lymphocytes / lymphoma, they are usually discohesive cells as well. They have also scant cytoplasm with some kind of chromatin, which look relatively like a neuroendocrine tumor, but not really. And sometimes you have this in the picture, but sometimes not. You have this they call it lymphoglandular bodies. These are just pieces of lymphocyte cytoplasm which peel off during making the smear. When you make a smear, some pieces of the lymphocytes, they punch off, and you end up having these small lymphoglandular bodies. These are usually there in lymphocytes or in smears of lymphocytes / lymphoma. These are called lymphoglandular bodies. They sometimes give them for you in the picture as a keyword of pointing out towards lymphocytes / lymphoma rather than neuroendocrine tumors. The melanocytes, melanoma, might take any shape, might take any form, but the thing is, I'm telling you, usually in the exam, they give you melanin. You'll see melanin inside the cytoplasm if they end up giving you a smear of melanoma. If they give you a smear of a needle aspirate for melanoma, it will usually have melanin in the cytoplasm. So cytoplasmic melanin pigment is usually there. But the thing is, melanin pigment by itself in the cytoplasm is sometimes tricky. You need to get used of how the melanin pigment look like in the cytoplasm. See these like globules here? These like globules that you see in the cytoplasm, that's melanin. when I see always a cell which has like a very, very prominent macro nucleolus, and sometimes multi-nucleated, as you see here, and I see this, what I say, it's a kind of greenish cytoplasm with some granules in the cytoplasm, a greenish cell with some granules in the cytoplasm. I always say that this looks like more towards melanoma side. Of course, the spindling pattern, you need to get used to this. Spindling pattern or cigar-shaped nuclei. This is usually a sarcoma or mesenchymal thing. It's mesenchymal thing or a sarcoma. Common non-neoplastic things that you need to get used to in cytology is when you see a lot of neutrophils, a spill. It's as if it's a bag of neutrophils and somebody punched this bag and it got spilled on the slide. When you see this spill of neutrophils, you're dealing with an abscess. Abundant neutrophils with necrosis and fibrin. This is abscess. So the next step, you need to do cell culture, or you need to do, culture. You culture it. You need also to get used to how granulomas look like. Granulomas are usually collection of lymphocytes and epithelioid histiocytes, or lymphocytes, macrophages, giant cells, which are epithelioid histiocytes. You usually have these confined collections. See these confined collections. Here's a confined collection or a cluster of cells, which some of the cells look like macrophages right there. And you see some cells acquiring a kind of epithelial-like cytoplasm. The cytoplasm is getting an epithelial-like tinge, which is pinkish. The pinkish cytoplasm is this epithelial-like tinge, and this is what we call the epithelioid cells or epithelioid histiocytes. You see these tight clusters of cells with macrophages all over, and some cells which have pinkish cytoplasm and having an epithelial-like architecture. This is epithelioid histiocytes. You say that I'm dealing with a granuloma. Of course, the next step is you do bug stains. You need to do TB stains and fungal stains, GMS, and do culture in order to rule out any infection which leads to granuloma like TB and some kind of fungi. You need also to get used to how necrosis look like on cytology. Necrosis look like dirt. I always say that. If you see on the slide that you're seeing a lot of dirt, it's like grungy. That's what grungy means. Like it's like as if it's some dirt spill on the slide. Grungy particle fragments and fibrin. Sometimes you will see some associated inflammatory cells like lymphocytes and macrophages. Well, not bad. That's necrosis. If I'm seeing necrosis, I'm suspecting one of two differential. What are they? The two key differentials that I'm suspecting when I see necrosis?
One of them is SCC.
Yeah, malignant. Any malignant, not only SCC. You might have it in adenocarcinoma, right? So any malignant condition in the CNS. Also, you might think about a glioma, a malignant glioma, or like GBM or something. But we don't get neither aspirates. We get like a crush smears in neuropath. But it's like I'm thinking of malignant. Or what else? What else other than malignancy? What's the category that you're thinking of when you see necrosis? Infection, not infarction. Infection. I hope that this is what you mean to write. Yeah, typo. Okay, infection. Because a lot of infections produce necrosis. Microorganisms produce necrosis or tissue necrosis where they reside. So usually you might see it in infections. So you need to do also bug stains. You need to do infection stains when you see necrosis as well. So my needles might be taking the sample or the specimen from the necrotic area of a tumor, or it might be taking it from a necrotic area of an inflammation or of an infection, an area of necrosis in an infection, or an area of necrosis in a cancer, right? Reactive lymphoid hyperplasia, we will talk about this in the heme path. We don't really need to look at it. Cyst fluid. What's the most important cyst that you might develop, that you might have cyst fluid from? Anybody knows? Ovarian cysts? Well, yeah, it's a yes, not bad. And what else? In the neck?
Thyroid.
Thyroid cyst. Okay. It's like the colloid cyst, you mean? Yeah, branchial cyst. Branchial cyst as well. Also epidermal inclusion cyst. Like if you have an epidermal inclusion cyst, you might get some keratin debris. I always say cyst fluid is whatever a cyst contains. Cyst fluid is whatever a cyst contains. And the cyst most likely contain fluid/debris. Fluid/debris means that most likely you will see some kind of low cellularity specimen, because you're not seeing cells, you're seeing debris, and you're seeing cyst fluid. So it's usually paucicellular with some scattered inflammation, which is usually in the cyst wall, scattered macrophages. And sometimes it may contain hemosiderin pigment. It could be a keratin-filled cyst. It could be a colloid cyst if we are dealing with a thyroid. It could be anything. Ultrasound gel, well, come on. We don't really need to dig into that. See, here he's telling you some other characteristic cytology features like the nuclear pseudo-inclusions that you might get in papillary thyroid carcinoma specifically. This is very granular looking cytoplasm, like crunched or crushed glass. And he's saying this is a specimen coming from the tongue, for example. If they're saying this specimen is coming from the tongue, and he has this granular cytoplasm, it could be a granular cell tumor. The tigroid appearance, tigroid background, this is usually in seminoma. Samuma bodies, you might see these in the papillary thyroid cancer as well, and papillary ovarian carcinoma, papillary serous ovarian carcinoma, or papillary serous ovarian tumors, mesothelioma, meningioma. You always say the two P's and the two M's. The two P's and the two M's. And the two M's are meningioma, mesothelioma, and the two P's, one up and one down, papillary ovarian, papillary thyroid. That's Samuma bodies. Okay, so that's an overview of some patterns of cytology before we start to dig in details. So what we learn here is how to differentiate between benign looking cells, malignant looking cells, how you can identify squamous cell carcinoma, how you can identify adenocarcinoma, how can you identify an abscess, how can you identify a cyst fluid, how can you identify small cell lung cancer, neuroendocrine tumor. These key cytological concepts and key cytological patterns need to sit down in the back of your mind before you start building the details. Okay? Now let's get started in cervical cytology. Sorry. Hold on a minute. Okay. So to get started and talk about the cervical cytology or the cytology of the cervix, you need at first to have the sense of how you can differentiate between normal lining or normal cells that line the cervix. Whether we have ectocervix or endocervix, and as you remember, in the pap smear, we usually have both. We sometimes have both, or usually we have both. We have some ectocervical cells and some endocervical cells, because usually we take the pap smear from the endocervix and the brush also take from the ectocervix as well. So ecto and endocervical cells, that's what we usually get. So how can we differentiate between the different cells of the ectocervix? The ectocervix is lined by what kind of epithelium? Squamous epithelium, or the stratified squamous epithelium. So in stratified squamous epithelium, we have the basal cells / parabasal cells, and we have the intermediate polyhedral cells, and then we have the superficial squamous cells, which sometimes is showing some keratin-like differentiation, but they are actually non-keratinized. We don't have any keratin in the cervix. So superficial cells, intermediate cells, basal, parabasal cells. You always look at the first look at the amount of the cytoplasm. The lower the cytoplasm, the lower the cell is. The lower the cytoplasm, the lower the cell is. So the low cells mean the basal and parabasal cells. They usually have very scant and minimal amount of cytoplasm, and they have a rounded to oval nucleus. And if you end up measuring the NC ratio here, you might be tricked. You might be tricked that you're having high NC ratio, but actually the cells in the smear look alike. They look uniform. There is no nuclear pleomorphism. But there is high NC ratio, well, but is there any nucleolus? Any prominent macronucleoli? No. There's no nucleolus. I see no nucleolus here, but I see just a cell with a relatively big, smooth, circular nucleus with uniform chromatin. If you split it to 4 quarters, you will see that they look the same, but little cytoplasm. So this is normal in the cervix because I have basal and parabasal cells which look like this. Minimal cytoplasm, rounded to oval nuclei. Fine dispersed chromatin. What's the condition in which you get a lot of basal and parabasal cells in the cytology smear and you get scant amount of intermediate and superficial cells? What do we call this? It's called what?
Unsatisfactory.
Not really unsatisfactory. It's usually atrophy.
Okay.
In case of atrophy. In case of atrophic cervix in a very old age lady, you might get abundant basal and parabasal cells. You don't get that much intermediate and superficial cells. This is what we call parabasal or basal cell abundance due to atrophic change or atrophic changes. However, if you have big amount of cytoplasm, then you are dealing with either an intermediate or superficial cells. You are high up in the cervix. How to differentiate intermediate from superficial cells is from the size of the nucleus. So after you looked at the amount of the cytoplasm, look at the size of the nucleus. If you see the size of the nucleus is relatively big, not small, we always compare to the size of lymphocytes. We always compare to the size of a lymphocyte. If the nucleus is around the size of a lymphocyte, it's intermediate cell. If the nucleus is smaller than the size of a lymphocyte, it's superficial cell. I always say it's as if someone used the thick marker and made a dot. That's superficial cell. If someone used the thick marker and made a circle, that's intermediate cell. So abundant blue cytoplasm and larger rounded to oval nuclei. But here, small pycnotic nucleus with abundant cytoplasm. Usually the superficial cells are sign of estrogen abundance. If you see abundant superficial cells in a cervical lining, this means that this lady is exposed to large amount of estrogen. Maybe she's in the first half of her menstrual cycle. In the first half of the menstrual cycle, you have large amount of estrogen, so you have abundant superficial cells. The cervix is relatively proliferating, and there is abundance of small cells, superficial cells, sorry. But otherwise, she might be taking estrogen pills whatsoever. But it indicates abundant estrogen. You need to memorize or remember that. Here is the endocervical cells. So we are done with ectocervix. Now we're moving to endocervix. Endocervix are always columnar cells with apical vacuoles. Columnar cell, here is a columnar cell. It's a long elongated cell with basal nucleus. And then you see granular cytoplasm or vacuolated apical cytoplasm. Here is columnar cells showing polarity with majority of cytoplasm occupied by mucin. Sometimes they have this honeycombing architecture, but usually most of the pictures that they give you in the exam, they look like this. They look really columnar, polar, with apical mucin. On the other hand, you might get some shedding of the endometrium in the cervical pap smear. So you might get some endometrial cells. The endometrial cells are a little bit tricky because they are very crowded. They are on top of each other. See, like this dense cluster, which is usually, they call it sometimes three-dimensional, as if you see cells on top of other cells, cells on top and cell on bottom. That's the 3D clusters, and relatively dense clusters. And sometimes you see some nucleoli, by the way, but they are usually micronucleoli. See, here is the nucleolus. Here is the nucleolus that I can appreciate here. But the nucleoli are usually micronucleoli. They are not macronucleoli. And the nucleus is around the size of an intermediate cell. Cells are tightly packed, large groups, and usually they are called benign endometrial glands. See, small, high NC ratio cells, almost all is nucleus. So please remember this. Micronucleoli, underline this, micronucleoli. They can be also large groups. You need to report the presence of endometrial glands, especially in a lady who's more than 50 years old. Because in a lady who's more than 50 years old, is it normal to see endometrium? No, because endometrium here is already atrophic. She's menopausal, right? She's postmenopausal lady. So you should not be seeing any large clusters of endometrial glands or endometrial cells like this. So definitely it's not normal in a postmenopausal lady. Adequacy in pap smear, you need to memorize the numbers, unfortunately. We have two types of smears in pap smear, liquid-based smear and conventional smear. Sometimes they call thin and thick smears or liquid-based and conventional. Which one is the most commonly and widely used? Nowadays, which is more common and widely used? Anybody know? The thin smear or liquid-based smear. The liquid-based prep is the most widely used right now. So when for you to tell that the specimen is adequate, you need to have at least 5,000 cells in a liquid-based smear or around 10,000 cells in a conventional smear. I always say 5,000 and the duplicate of 5,000. So 5,000 and 10,000, around 10,000. So from 8,000 to 12,000. Okay, it's around 10,000. So 5,000, 10,000. Liquid-based, conventional, thin, thick. Thin is less, thick is more. Okay? And not only the number of cells you need to put in consideration, you need to put in consideration the number of well visualized squamous cells. So this number of cells, we are referring to the well visualized squamous cells. Because if you see a lot of cells in the pap smear, but most of them are just dirt, just necrotic cell or neutrophils, inflammatory cells, well, this is a lot of obscuring elements. If the obscuring elements is covering more than 75% of epithelial cells, this is considered unsatisfactory. If you see a single cluster of SCC, squamous cell carcinoma, but the remaining pap smear is all like necrotic and all trash and all dirt and no cells, would you call this a satisfactory smear? Yes. Please don't say no. Never. Any specimen with abnormal cells is considered adequate and should be reported, regardless of what you see in the background. As long as you see a single cluster of SCC or a single cluster of squamous cell carcinoma, you're done. This is diagnostic. This is satisfactory. You don't really need to look at the background and say, oh, the background is so dirty, I don't see any other cells. Well, this smear is unsatisfactory. Nope, there is squamous cell carcinoma there. So it is adequate because it has abnormal cells. Okay? All right. Thumbs up until now. Everything is good? All good? Perfect. Perfect. Now let's go over some pathologies. The first thing is the squamous intraepithelial lesion. And of course, what I only need you to know from the cytology perspective is apply the criteria, shoot for a diagnosis. I don't want you to know the details of what LSIL means or what's the difference between what's the academic or theoretical base of LSIL. This you will know when you study cervical pathology or cervical histopathology or surgical pathology. From the cytology perspective, I need you to learn how you identify LSIL in a smear. That's it. That's what you need to develop. A lot of people rely in LSIL on the perinuclear halo. The perinuclear halo here. See, here's the nucleus, and here is a huge area of haloing or a huge area of large irregular clearing around the nucleus. This is what we call the perinuclear halo. I will partially agree with those who rely on the perinuclear halo to diagnose the LSIL because it's there in most of the pictures, even in the exam. Even in the exam, they will provide you with a picture with a huge perinuclear halo and tell you what's your diagnosis. But the problem is, it's not specific. It's not specific at all. See, he's saying that this is optional. You might find, you might not. You might find it, you might not. So you cannot rely on this 100% in clinical practice. Possibly for the exam, 80%, I would say. But what about the 20%? We need to know about it. The key thing is to measure the nucleus. Measure the nucleus. You will have relatively bigger nucleus. Well, intermediate cells have big nucleus. You said this. You told us that, like a couple of minutes ago, that intermediate cells have big nucleus. No, this is even bigger. Well, how can I develop the sense of differentiating a big nucleus versus a bigger nucleus? This is what you get by practice and by looking at a lot of pictures. We had a cytotech in our program. She always told me if it's like 1 tablespoon of sugar, that's intermediate cell. If it's 2 or 3 tablespoons of sugar, that's a huge nucleus. And they always say you need to compare this. Usually they give you a picture of a normal intermediate cell in the field. Like in the same field, they'll give you, like here, this is, I think, a normal intermediate cell. So that he's giving you the control in the same picture. Like in the same picture, it's giving you the control, the one that you need to compare the size of this with the size of that. Usually the size of this is at least 3 times the size of an intermediate cell nucleus. What if it's bigger than the intermediate cell nucleus, but it's not 3 times? It's a little bigger or 2 times bigger. What do you call it? Anybody know? Is it LSIL? Does it qualify as LSIL? What do you think? What will you call it?
Maybe ascus.
Yes, we call it ASCUS, or atypical squamous cells of undetermined significance. And I will tell you something. ASCUS is an extremely, extremely rare diagnosis in the board exam. They hate giving you the gray zones. They want you to identify clearly the LSIL, HSIL. They won't bother giving you an ASCUS. It might happen, but I'm saying it's rare. So in LSIL, you will see enlarged nuclei, which is at least 3 times the normal intermediate cells, with some kind of membrane irregularities, but not really. But there's no nucleoli. You can't appreciate any nucleoli. You might see some multinucleation. You might see this perinuclear halo, as I mentioned, but this is fine. See, it's saying consider ASCUS, which is usually the nuclear enlargement is not to the point of saying that this is 3 times the intermediate cell. It's like 2x or 1.5x. They are saying you don't have enough criteria to call it LSIL, so you call it ASCUS. And I'm telling you, ASCUS is very rare. Make sure you identify the LSIL first. LSIL, you need to remember that it's caused by high and low risk HPV. Even low risk human papilloma virus might give you LSIL, but high risk give only HSIL and squamous cell carcinoma. That's what usually happens here. So this is the HSIL. HSIL, you get a very, very, very huge and irregular and pleomorphic nuclei. Very huge, which what I mean by, of course, NC ratio, high NC ratio, very huge, irregular, pleomorphic nuclei. Is there any prominent nucleoli? This is a question for you guys. Is there any prominent nucleoli here? No, because we are still talking about SIL, squamous intraepithelial lesion. We're not talking about squamous cell carcinoma. So see, you're getting immature keratinocytes with high NC ratio also, and irregular nuclear contour, enlarged with irregular chromatin and hyperchromasia. This means that you don't see any nucleolus. So see, this is when you're dealing with rocks. This is when you're dealing with rocks. If you still also have some of the features of HSIL, but it's not enough to call it HSIL, you call it ASCA, which is atypical squamous cell, highly suggestive for, or cannot exclude high grade squamous intraepithelial neoplasia. never happen in the exam as well. Just make sure you identify LSIL, HSIL, squamous cell carcinoma, tadpole. Only? No, tadpole plus pleomorphic huge nucleus, sometimes prominent nucleolus, and dirty background if present. So see, if you see tumor diathesis or necrotic debris in the background, prominent nucleoli, and the tadpole cell, which look like a sperm, as we mentioned. Tadpole, snakes, sperm-like cells, that's keratinizing SCC, or that's squamous cell carcinoma. Okay. That's it for the squamous abnormalities of the cervix. Let me just take a water break. Just less than 2 minutes and I will be back, okay? Just less than 2 minutes. Okay, I'm back. So let's continue. Now we're talking about the glandular abnormalities, which is like the glands. We mentioned the benign endocervix, which is relatively like having some kind of glandular epithelium, or just an epithelium with apical mucin. As we mentioned, it's like endocervical glands or benign endocervical glands, but this is the physiological glandular epithelium, or how the physiological glands looks like. And we also talked about the benign endometrium, or the benign endometrial glands, or the benign endometrium, how it looks like. Now we're talking about glandular abnormalities. This is an important one. The endocervical AIS, or the endocervical adenocarcinoma in situ. This you need to remember. More than this, you rarely see this in your exam, like reactive endocervical cells. Oh, come on. A cytologist actually might not be very sure of diagnosing a reactive endocervical cells versus endocervical adenocarcinoma, this kind of thing. But endocervical adenocarcinoma in situ, you need to clearly identify. This is what we call the feathering. The feathering is called feathery edges. Like if you look at the edges of this, it's like as if there is feathers. This is what we call the feathering. It's as if you're seeing a wing of, let's say, a chicken or a wing of a bird, and these are the feathers of the wing. So seeing feathery like a bird's wing. And when you look at the cells carefully in this feathery wing, you will see that the nuclei are large This means that you are having high NC ratio, and you see dark, coarse chromatin with cellular crowding, but no nucleoli. No nucleoli here is very important. Because if you see prominent nucleoli, what would be your diagnosis? If you see prominent nucleoli, prominent macronucleoli, what would be your diagnosis? And the same thing, like crowding of cells with large nuclei. However, the chromatin is not so condensed to the point that you see prominent macronucleoli. That's adenocarcinoma. And that's how you develop the sense of differentiating endocervical adenocarcinoma in situ from an actual adenocarcinoma. See the actual adenocarcinoma? Well, you still have the large, huge nucleus, high NC ratio, crowding of cells. I agree. However, the chromatin here is not so dense. It's a kind of irregular chromatin, vesicular chromatin, I always say, and you see large, huge macronucleoli, which are usually visible. And if you look carefully at the cytoplasm is not so plenty because the nucleus is taking up most of the cell. But you have some cytoplasm. If you look carefully at the cytoplasm, you see that the cytoplasm is kind of granular, or it's vacuolated, like it's a glandular cell. So, see, features suggesting invasion: macronucleoli, necrotic background. Well, I agree. Tumor diathesis is there in any malignant tumor. You sometimes see some single cells going outside the groups or outside the group, but it's not very specific. But I would say that this is a feather or a feathery wing, but with prominent macronucleoli and maybe background necrosis. Well, this is adenocarcinoma, but from where? Is it endocervical adenocarcinoma or endometrial adenocarcinoma? How can we differentiate both? How can we differentiate this from that in the board exam? I'm not saying in a real case. In a real case, sometimes you have a diagnosis from the radiology or whatsoever. But in the exam, how can you differentiate endocervical from endometrial adenocarcinoma? Well, both of them have this like feathery wing-like groups of cells with large nucleus, macronucleus, high NC ratio, irregular nuclear contour and nuclear pleomorphism, macronucleoli. But what else? No. The bag of polys. Please remember this. He didn't mention this term, but I want you to remember it. The bag of polys. Anybody told you this term? Anybody told you this term before? Bag of polys? Bag of polys means bag of neutrophils. Bags of neutrophils. You see that there are sacs of neutrophils, or groups of neutrophils clustering in endometrial adenocarcinoma. So the key factor that's favoring endometrial adenocarcinoma is neutrophils. No, not neutrophils. It's bags of neutrophils or bags of polys. We will see a picture of that in our training session. In our training session, which we will get a lot of images, we'll see pictures of that. Okay? Well, some cancer mimics. What I mean by cancer mimics is conditions which really resemble cancer. And unfortunately, these are really tricky. Like, I can't count how many times I got tricked by a reparative change or inflammatory change. Reparative change or regenerative change. They call it sometimes reparative change, inflammatory change, or what they call it, a reactive change, reparative change, inflammatory change, whatsoever. That's when there is injury and the cells are in the stage of repair. They are proliferating to repair itself. So the thing is, what's the source of proliferation in any stratified squamous epithelium? Which cell proliferate to regenerate the other layers of the cells? The basal and parabasal cells. The basal and parabasal cells. So when there is injury and there is a current repair process happening, so what you will see is, you see that there is less superficial cells, nearly there is no superficial cells, and you see clusters of basal / parabasal cells. But these basal / parabasal cells, they have sometimes prominent nucleoli, but they are micronucleoli. They are not macronucleoli. And this is how you differentiate it from a carcinoma, by the way. So like, see, here we see nucleoli, but can you compare this nucleolus to this nucleolus? What do you think? Please give me a thumbs up if you can tell the difference between this nucleolus and this nucleolus. All right, so look at the nucleolus. When you see micronucleoli and you see cells with less cytoplasm, more nucleus, that's the basal / parabasal cells. And you see the cells are grouped in clusters. They sometimes say streaming-like pattern. Sometimes they call it school of fish. I don't know if you heard this term before, like a school of fish, or like a group of fish swimming in the sea. This is a school of fish. This is how the basal parabasal cells cluster in case of reparative changes or inflammatory changes or reactive change. You have reactive cells, you have prominent micronucleolus, and the cells are mainly basal parabasal, and they are showing some cohesive flat sheets, cells with streaming architecture, rounded nuclear contour, sometimes a prominent nucleoli and enlarged nuclei, but the nucleoli or the nucleolus is just a micronucleolus. Everyone will get this picture in his exam. I'm sure. I'm sure you will get this picture in your exam. Everyone. Yeah, you will get a picture with a perinuclear halo, which is very clear. Whoever is blind can see this perinuclear halo. And they want to trick you that you go ahead and diagnose it as what? What do they want you to trick? What's the trick? They want you to diagnose it as LSIL. They want you to say that this is LSIL. But actually they give you choices. That's usually the case. They give you the choices. Is it LSIL? HSIL? Reactive changes? Or sorry, is it LSIL, HSIL, ASCA, or negative for dysplasia and malignancy? So what would be your choice? It's negative for dysplasia and malignancy. They don't give you the choice of infection. No, they give you a choice of negative for dysplasia and malignancy, as if they are tricking you, that you say, oh, come on, this can't be negative. This can't be negative. I see a pathology, or I see a perinuclear halo at least. So this can't be negative. No, please continue reading. They are saying negative for dysplasia and malignancy. And it is negative for dysplasia and malignancy. It's just an infection case. And infection doesn't mean dysplasia. Infection doesn't mean malignancy. So this is inflammatory change or inflammatory change, which is a sign usually of ongoing infection or active infection, like trichomonas, chlamydia, or candida. And what's the key difference between this perinuclear halo and that perinuclear halo? What's the difference here?
Not 3 times as large.
Again, what did you say?
It's not 3 times larger than this one, I think.
Yeah, it's like the size.
Yeah.
Yeah, the size. This perinuclear halo is so big. This perinuclear halo is as if someone is just highlighting the nucleus, you know? Can you see that? And like Muhammad, can you see like it's like as if someone is highlighting the nucleus with a white marker. It's just
Yeah.
a highlight. When you know when you do Photoshop and you just like make like a bevel for the letter and you make like a little like the letter look a little shiny. That's how it looks in this inflammatory perinuclear halo. So when you see a little bit of a halo, a little bit of a clearing, it's like as if there is a glow in the nucleus and that's it. It's not very huge, very prominent. So you start doubting that this is an inflammatory one. This is a general inflammatory change. It's not LSIL. Okay, so mild nuclear enlargement here. The nucleus here is not 3 times the size of an intermediate cell, but it doesn't even qualify as ascus. You still see some small perinuclear clearing. See this sentence? Small perinuclear clearing, which doesn't qualify as a perinuclear halo. Okay. Next is atrophy. Atrophy sometimes look very funny, like what you see here. So sometimes when you look, oh, well, look at this. This is very dirty. And see these large blue things. That's malignant, definitely. No, this is not malignant. You see the history, they will tell you that this is a very old age lady. Very old age lady, and you see these, oh, that's it, that's it. That's just atrophy. All what you're seeing here are basal. These are basal parabasal cells. There is no intermediate or superficial cells. And you see a lot of these blue blobs. They're called blue blobs. Blue blobs and some kind of granular debris. Why? Because you're having some degenerating cells. Because what's the cause of atrophy? It's the menopause. In the menopause, you lose estrogen, and the estrogen is the source of life for the cervical lining and the cervical epithelium. So you end up having some kind of cellular degeneration, and the cell degeneration, you end up having some cell debris or cellular debris here and there. And this is what we call atrophy. Atrophy is seen in low estrogen states like postmenopause or postpartum, because in postpartum you have progesterone predominant status, and in pregnancy you have the pregnancy hormones, which have also LH-like activity and anti-estrogen activity. Premenarche and also in Turner syndrome, where there is low estrogen because you're missing one X chromosome. It's usually seen in basal and parabasal cells, and you often see the cells with high NC ratio. Essentially, you're seeing most of the time these cells with large nucleus, but still rounded, regular. And you see these blue blobs and granular debris that might trick you for cancer. This thing also is very, very, very common in the RISE exams and in the board exam. You see this large, multiple melted nuclei. I always see that. I always say that. Large, multiple melted nuclei. Large multiple melted nuclei, that's radiation change or that's irradiation change, not only in the cervix, anywhere. You might have radiation changes in the lung. You might have radiation changes in the ovary. You might have radiation changes in the cervix, and it's always the same case. It's always the same thing. Cytomegaly. So you have cytomegaly, big cells with big nuclei, large, the cells are large, looks bizarre, and there's cytoplasmic vacuolization and multinucleation. The nuclei are large, big, fused together and melted. I always say they have like a melted, as if you heated the cell and the nuclei are melting. That's irradiation change or radiation change. By the way, the most specific radiation change is nuclear enlargement or nucleomegaly, cytomegaly, multinucleation, cytoplasmic vacuolization. What do you think? I looked it up. I got this question. I don't remember whether it was in a RISE exam or in a board exam, in the board exam. I don't really remember, but I Googled it. I didn't find a clear solution, or I didn't find a clear answer, honestly. I will wait for your search, guys, and you just let me know, because until now, I don't know. Because they give me all the choices, and all the choices looks correct, but I don't know which one is the most specific. But I believe it's the nuclear vacuolization, which is like the melting of the nucleus. But I'm not sure, of course. I have no idea. Just you let me know. Maybe ask an expert. If you have an expert, and ask the expert and let me know what did he say. But this was a question, actually, but I don't remember where. Anyway. So, the other thing is when you see clusters of lymphocytes. See, lymphocytes, 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 a lot of background lymphocytes. When you see a lot of background lymphocytes in a lady in her reproductive age, what should she do? What should she do? You see also some with the lymphocytes, you see some macrophages, sometimes tingible body macrophages whatsoever. It's as if you are seeing reactive follicular hyperplasia. You see lymphocytes, macrophages, and tingible body macrophages. What do you think? What should this lady do? She should test for chlamydia. That's a question that I also got, but I won't tell you whether it's a RISE or, but she should test for chlamydia, because chlamydia usually present with follicular cervicitis. It leads to chronic cervicitis to the point that the chronic inflammatory cells make lymphoid-like follicles. The lymphoid follicles have lymphocytes, macrophages, and tingible body macrophages. Here's the lymphocytes here, and tingible body macrophages. When you see a lot of background lymphocytes, a lot of background plasma cells, a lot of background macrophages, everywhere in the slide, and you see some interspersed cervical epithelial cells here and there. That's follicular cervicitis. That's chlamydia infection. The wedding ring. The wedding ring. What's the wedding ring? Here it is. A cell with a compressed peripheral nucleus and the large, huge single cytoplasmic vacuole. Sometimes they are multiple but big. Multiple but big, huge cytoplasmic vacuoles. That's accumulation of secretions. What kind of hormone usually lead to secretory change and lead to abundance of secretion? Is it estrogen or progesterone? It's usually progesterone. And what kind of thing this lady might have which lead to this kind of reactive looking epithelial cells? They look bizarre, but these reactive looking epithelial cells having this accumulation of huge amount of secretions, that's a progesterone secreting IUD. That's a progesterone secreting IUD. That's why they always say when you see weird looking cells with abundant, huge vacuolated cytoplasm and small dark peripherally located nucleus, always check the history. Always check the history of your patient, whether she has an IUD or not. The classic 3Ms, margination, multinucleation, and molding. I know that you are an expert in this one. Well, you see this marginated chromatin, multinucleated cell. See this multinucleated cell? Marginated, multinucleated, and the multinucleated cells have this molding of the nuclei. So molding, margination, multinucleation, the 3 M's with the ground glass chromatin looking, that's herpes, and you need to treat with acyclovir. Remember this. Small nucleus, relatively bigger nucleus, that's superficial / intermediate cells, but highly likely these are superficial cells actually. Well, superficial / intermediate cells. But what the heck is going on here? So see this dust, like this spray of dust that you see on top of the cell. It's as if there is a layer of dust on top of the cell. I always say it's dusty cell. A dusty superficial cell means a clue cell. A dusty superficial cell means a clue cell. So see, it's covered with shaggy bacilli. That's the dust which is sprayed like this. These are actually usually Gardnerella vaginalis. Most commonly, this is Gardnerella vaginalis, and this happened due to shift in cervical flora. Shift in the flora. Instead of having this normal lactobacilli, you have a shift in the vaginal pH, which lead to decrease in the number or in the amount of lactobacilli and increase in the Gardnerella vaginalis. That's called shift in vaginal flora. It's usually related, by the way, to frequent sexual intercourse. This is because when there is frequent sexual intercourse, there is usually deposition of semen in the cervix and in the vagina, and the semen is alkaline. So it leads to shift in the vaginal pH, and this leads to a kind of distortion in the balance of the vaginal flora. You end up having less lactobacilli and more Gardnerella vaginalis. Trichomonas, the tricky trick. The tricky trichomonas. Why they call it the tricky trick? Because it's usually not obvious as you see here. Well, here, yeah, that's a textbook trichomonas here. I see this pear-shaped organism which look like a pear fruit with this nucleus and red dotted cytoplasm or red cytoplasmic granules. I'm sorry, but you will never see it like this. You will never see it prominent like this and that. That's a textbook case. This never happened, neither in your RISE exam nor in the board exam. But when do you start doubting that there is a trichomonas vaginalis in the area? When do you start doubting that there is like a kind of, you should search carefully for the tricky trick? Yes, sir. Neutrophils in the background. Background neutrophils. I see a lot of background polys. This means I'm dealing with an acute inflammation. And acute inflammatory condition means acute infection like trichomonas or candida. So you start looking for trichomonas or candida. Also, when you see the little perinuclear clearing, which doesn't qualify as a perinuclear halo, if you remember, that's acute inflammatory change, which is not present here. It's not here. But here there is a lot of background neutrophils. And usually this is the case. Either they will give you visible trichomonas. That's usually the case in the pictures. In the pictures, either they will give you a visible trichomonas, which is there. You can see it. If you are like a detective, you can see it. Yeah, well, it's there. So I don't need to show background neutrophils here in the picture. Or they will hide the trichomonas somewhere. They will hide it inside one cell, or they make it overlapping with a nucleus or whatsoever. But they will give you a lot of background neutrophils to test how you look or how you approach a picture. Well, I see a lot of background neutrophils. This means that I'm dealing with infection. Let me look carefully and see. I don't see anything. And then you look at the choices in the MCQ. You see only one choice which has infection, like Trichomonas vaginalis. Well, okay, I would choose this because I'm doubting infection here. Maybe I cannot see it, but it's there. That's how you deal with the questions. It's all based on how you observe and how you interpret findings. Okay? Another thing is Candida. Candida, you have this, they call it shish kebab. I don't know if they told you the same thing or not. If whoever was explaining cytology to you told you this shish kebab sign. Shish kebab means it's like the shish kebab, like you see the cells with the stick. The sticks of the shish kebab is the Candida. Or sometimes spaghetti and meatballs. It's like a spaghetti and meatball bowl. So see, like these are the spaghetti here. The spaghetti is right there. And the meatballs are these cells floating here. Spaghetti and meatballs. Of course, this is what you see, the pseudohyphae. The pseudohyphae. And what you see in the background is the squamous cells. What you see in the background is the squamous cells. When you see this tuft of hair, when you see this hair ball, or they call it dust bunnies, dust bunnies or hair ball. What do you call it? Actino. This is actinomycetes, and actinomycetes is an organism which exists usually in the ladies placing IUD or intrauterine devices. So that's IUD associated actino. These are long filamentous organisms. That's why they look like a dust buns. They aggregate in long filaments, and they make these dust bunnies or cotton balls, or I always call it hair balls, hairy balls. That's the actinomycetes. Thumbs up on what we have explained today. Everything is good? Next time we will practice on cervical cytology, and I will tell you the next step, the common next step in management. Although, honestly, I didn't have any question asking about the next step in management in my board exam. I usually had questions about LSIL, HSIL, infection, follicular cervicitis, these kind of things. But we will go over the key next steps in management, like a brief. And then we will go over this presentation next time. I will show you. Let me show you. We'll do like this. So next time I need you guys to do your homework and try to study this notes and try to clearly identify the differences between different entities. So see, this is the plan for the next time, okay? Here is the plan for the next time. Yeah, I will show you a picture like this, and you will tell me the diagnosis. And then I will show up the diagnosis, reactive squamous cell. And then I will show you another picture. You tell me your provisional diagnosis, and then I will show the diagnosis. Same thing. We'll go over nearly 30 or 40 pictures, or even more. I will try to include as much pictures as I can, and we will even include some repeated entities, like Sometimes I will get you a picture of LSIL, and after 2 pictures, I will get you another picture of LSIL, so that I try to test how you can apply the criteria, okay? So we had a deal, Abdurrahman, everything all right? We have a deal. Maria, need you to do a good job. Muhammad,
Thank you.
okay, Muhammad,
Yeah,
run
thank you.
away. Don't run away next time, okay?
Oh, yeah. I won't.
All right, so just make sure you go over the basics, the two key notes, and for these 2 notes, I need you to apply the criteria that I pointed out in the lecture. How to differentiate the macronucleolus from micronucleolus. How you differentiate the cohesive clusters from the relatively discohesive clusters. So these kind of things and these gray zones and the small points that you use to differentiate entities from each other. These I need you to go over as many times as possible, so that next time when we apply by pictures, you will hit the correct answer most of the time. I know it gets like, it's usually depressing in the beginning, but then when you get used to it and you look at a lot of pictures and solve a lot of questions, you will be more and more comfortable until your exam day. Okay, thank you very much and see you next time. We'll stay in touch on the Telegram group. Okay, see you.